Hello everyone. So we'll continue with a presentation about indoor air hygiene. My name is Andreas. I'm a specialist for tropical medicine, infectious disease and hygiene. And first of all, I want to apologize because I may be actually coughing during that talk. I just arrived this morning from teaching in Ghana, and actually we started out with one coughing student and we ended with 20, including me. So actually, I'm a living testament of the importance of air hygiene and air quality right now, because it's actually really hot in Ghana, so we had an AC system running all the time. Anyway, let's just jump right into it. So the agenda, what you're about to expect, is a little bit more academic probably than it is product related. But I want to go over a little bit about how we transmit infections, because in the hygiene field we often lose track about the whole evolution side of how that works. Management of transmission routes, how we currently do it, and then evidence of spread through the air and what we can do it. And then of course the problem how to implement everything like that, because in the hygiene that is probably one of our most complicated things, how to actually implement stuff. So I want to start with the general idea of infections. Infections have been with the human forever, right? And we have co-evolved with the infections. And all these infections have used every single natural behavior a human has to actually jump from human to human, right? And the host can use a lot of protection against it. And we all have our skin, for example, which is a formidable barrier. However, there is also a lot of other barriers that are not that strong, which is, for example, the digestive tract, the reproductive tract, the eye, or the respiratory tract, because these are mucous membranes, they have to exchange substances, so they cannot be that armored. So it's clear that infections will use all of these easy entry sites whenever they can get them, right? So this is where we get most of our infections from. However, we're smart guys, so we can also react to this by changing our behavior, such as hand washing, for example, or we can also use technical advantages, right? We have invented the sewage system. We do water treatment, so we have safe water to drink, and we pasteurize our foods. So that's actually pretty cool as well. Now, when we look at that, it is clear that we have different ways of getting the disease from one person to the other. And the classic one is a direct interaction between two humans, right? We touch each other, we touch one wound, we touch the next wound. We have sexual intercourse, we do other things, right? And we can do that indirectly with our hands, with some obstacles that we contaminate and bring them from one person to the other. So of course, we have spent a lot of effort in actually controlling this route of transmission. So we have the hand hygiene moments from WHO, we have glove use, we wash our hands, right? We have contact precautions a lot in all of our rooms. We do have surface cleaning, we have washing, and we have single-use items everywhere. So that's actually why this is pretty much reduced right now. We do also do proper quality for what we eat and drink, right? So I don't worry to get diarrhea if I drink this bottle anymore. We do have vector-borne diseases, which still are a big trouble, and as me, a tropical medicine guy, a special thing for me. We just had World Malaria Day, so you know that personal protection against vectors is also a thing, and we can do that. But we've gone most far in actually stopping parenteral transmission, right? We check every blood transfusion for a numerous amount of different pathogens. We use single-use item for almost anything, sterile gloves, and so on and so on, yeah? But if you think about what we are breathing, what are we actually doing, right? So we did use a lot of these masks during COVID, right? And currently now we are not really using it anymore that much. There is filters that you can put in some room where you can filter your air that generate noise and wind and stuff. And you could also use UV to actually decontaminate the room air. But we mainly use this, which is HVAC systems, so we use systems that ventilate our rooms. Probably there's one here too, which should bring in fresh air and get out the polluted air. But they're actually not made to protect us against infection. They're made to reduce the smell, get fresh air, and remove the carbon dioxide. So why is it that we didn't do a lot of that yet? So if we look at our successes, and I think we are here in the hygiene field, and I'm also a hygiene guy, and I think we can congratulate ourselves also of what we have achieved, right? Because probably no one was alive 1900 of us sitting here, but and then the crude death rate was 800 out of 100,000 in the US, and it actually dropped down pretty fast until like the 1970s or something, where we actually reduced something we achieved something like 50 out of 100,000. Now, that was caused mainly by sanitary improvements, by hygiene improvement regarding hand washing and dishwashing, bathing, and all these kind of things. And then at the very end, we had mass vaccinations, right? We eliminated the smallpox. We almost eliminated the measles. They're back now. And we introduced antibiotics as well. But still, since the 80s, we don't actually have improved that at all anymore. We do see the HIV peak, but we are back to that about 50. And when we look at what that is, it's mostly lower respiratory tract infections, right? It's pneumonia, it's influenza, and of course, there's a considerable share of sepsis and stuff like that, wound infections in there too. But the lion's share is actually respiratory. Now, we have reduced our infections a lot by a factor 16 last 100 years, and I think that is really awesome. And we don't worry about our food hygiene anymore, right? In Africa, when I'm in Ethiopia, I'm really worried what I eat. Here, that's not the case really, right? And the same is true, we don't worry about our toilets, they just work, right? For the surface and hand hygiene, we all know we have our challenges regarding adherence in hand hygiene and stuff like that, but overall, I think it's pretty well managed as well. Protection against erogenous spread, we actually don't really have it, right? We do have a few wards that do have that, like our bone marrow transplant wards and stuff like that. But other than that, we are not doing a lot anymore. And only COVID actually forced us to look into this, right? With much, much more diligence that we did. And what came out was a very interesting document from the WHO from April 2024. And this actually, you might consider it, and I'll tell you what it says. It is a report on how to change to think about transmission through the air. So this used to be the dogma. The dogma that we had in the past was there is two kinds of aerosols coming out of human. There's the aerosol, which spreads forever, and there is the droplet that just drops, right? However, that new document says we have IRDs, infectious respiratory droplets. And they come out of the human. And if you analyze what comes out of human, you find it has all kinds of shapes and sizes. And actually, after it exits your mouth or your nose or whatever, it actually changes a lot because it depends on your humidity of your room. It depends on the temperature, on the wind, and so on. So there is no distinction between these populations, actually. We do know, though, that different diseases transmit with a wide variety of efficiency from one person to the other with that spread. But we don't differentiate between the two anymore. Now, we do know that there is a lot of diseases that have been spreading with aerosols very efficiently all the time, right? That was acknowledged. We were all afraid of that measles child coming onto our ward when we have unvaccinated children because they don't even have to see each other and the other one will already be sick. So this is how efficient, if you have the right pathogen, that will be. And the same is true for chickenpox, right? It's also shown for influenza, norovirus, tuberculosis, you name it. So there is ample of evidence of diseases that do that. However, since COVID, a lot of more technologies have been invented to actually study the problem better. And we are now knowing that aerosols are actually, or infectious respiratory particles for that matter, actually a very efficient way of spreading many, many diseases with different kinds of efficiencies. So I would conclude that air hygiene is one of the big topics of our time in the field of hygiene at all. The problem is, good data on that is really hard to get. Why? Well, we can't change breathing, right? We sit here, we breathe. Like wherever we are, we can't do anything. We can't help it. We could probably stop it for a minute, but that's it. So basically, it's a behavior that's linked to us. So how do we randomize a study? We can't put one group, non-breathers, breathers in here. That doesn't work, right? So there is no comprehensive studies on that. And also the WHO was pushing, before they put that out, they were pushing so much on the hand washing and surface thing that they were basically actively pushing off the aerosol spread because they didn't want to go into that problem. But COVID actually forced us to look into it. Now we have to look if there is any studies with targeted interventions to put a scientific number to the effects that we have. So what can we do? We can actually use as of notifiable diseases that we know are aerosol-borne, right? COVID, influenza, and a few others. We can use surrogate markers, then we have an intervention, and we check how many people are actually sick, because sick leave days are in the books, right? And we can use air hygiene interventions that have been taking place in the past. So I want to direct your attention to these two studies. I'm absolutely not related with these studies at all, actually. although I work in the same field. So the upper one is an Italian study, which I like a lot. It's 205,000 students in 10,000 classrooms. I would say that's a pretty massive study. It was conducted during COVID, and what they did is they randomized the rooms into the amount of fresh air or decontaminated air, for that matter, they had in that room, and calculated what was the effect on the sick leave days of the students or of the COVID cases. And what you see is that there is a clear-cut correlation. For every 1 increase of air exchange per hour, there is a decrease of 12 to 15% of cases. Now, the study below is almost 100,000 students. It's from the US. What they did an intervention. So they put in these classrooms UVC or HEPA filter decontamination and showed how the COVID numbers would change in the students. And it actually led to a reduction of up to 48% of COVID cases. Mind you, in both of these studies, the students were still coming from their normal home, going back to the normal home, and have their other activities that they had, right? So this is only for the time they spent in classroom. I find that pretty impressive, to be honest. But if we dig deeper, we find there is ample of evidence also before COVID. Like the upper study here is really interesting. It is 26 years old, and it is a room, like a building with offices inside in the US. And what they did is they increased in some rooms the air exchange rate from 12 to 24 hours per liter per person per second. And what they found is that the reduction of sick leave days in these rooms was actually 35%. This study here is actually quite surprising too, because it's from 2015, and it is 20 different childcare facilities in Europe. And what they did is they increased the air exchange rate as well. And what you see is exactly the same we saw with COVID, 12% reduction of sick leave days in infant care when you increase the air exchange in 1 per hour. And even the evidence is much older. So this is actually quite funny. So during COVID, people were digging up a lot of old data. And they found that when in the 1930s, the first UVC bulbs were actually developed, they were hanged in schools. So they would actually put them up in classrooms and just have all the students sit below those. We wouldn't do that today, right, because of UV light. But at that time, that was done. And actually, they could prove a reduction of sick leave time that was in the books in these students in the winters from 1940 to 1949 of up to 50% during the winter season by stopping the transmission in the classroom only at that time as well. There was reduced measles outbreaks. There was a reduced influenza in an outbreak 1959 in a home for the elderly, 80% less cases. I think this is all data that fits together. If we have more fresh air, we are actually more healthy. So you would say 12 to 15% per 1 air exchange per hour, fine. Up to 50% reduction in sick leave days, that sounds unrealistic, right? Because this is really, really high. So why on earth do we have this high number? Well, do you remember why I told you all the history about hygiene? Well, the trick is that a lot of our thinking is still based on the other hygiene interventions, and they are really effective, right? But that means what is left is what is left. And that is based a lot on aerosol. So basically, if we want to increase on what we have already achieved, we need to target what we did not target yet, right? So that is working. Still, you might answer now, well, but I don't remove everything, right? How can I remove if I just ventilate more? I will still be sitting with the other people. How does it work? Well, because we don't need that situation here. That's a BSL-4 award, right? And we don't need this situation to be really protected and to get a better outcome, right? The trick is dose matters. So what is it that makes us sick? For influenza virus, you need more than 100,000 particles to actually get sick. So they accumulate. So you have the time to concentration gives you the dose. That's relatively simple. We have no dose, no disease, high dose. You have a trend to have more severe disease. So what do we do when we dilute the pathogens? We move from the right side to the left side here. So that means we have more people that will not get sick at all, and we have more people that go from a more severe sickness to a very mild or even an occult immunization setting, especially in diseases where they have a pre-existing immunity. They get very low dose. The immune system has time to adapt and to respond and kill it before we get symptomatically sick, right? So what can we do in buildings to actually achieve that effect? So most modern buildings still have windows. So what one way we would do is we would use window ventilation. We open the window, we get more air. However, this actually never achieves a ventilation that's above 1 per hour. And we all know it's infeasible if it's hot or cold outside, if it's loud outside. And there's always that one person in the room that doesn't want the window open. You all know that. Then we have the HVAC system, right, which is in all normal buildings. But it is made to remove carbon dioxide, maybe provide heating and cooling, and it does not go above 3 to 5 air exchange rates per hour, which is not enough for a safe system. Besides that, you would need to have a filtering in your system to actually provide fresh air. And that, for most of these systems, these filters are not safe to actually remove microbes, or you would have a UV decontamination in that one to remove it, and most of these systems actually do not have it. Besides, if you have one that runs on high power, like in my labs, for example, that's really expensive to run. So you want to turn it down if you don't need it in one room, and this is a fishy thing with all these HVAC systems. Now, the decentralized ones have become popular, so you have a small device you put in some room and you actually decontaminate the room specifically, which is a smart idea if that room is a special room that you really want to target. And you can combine it with existing system. And I think if you combine it with an HVAC system, this is actually really cool because they complement each other. And I would call that the hybrid system, which is probably the most cost-effective and versatile that you can achieve in a room. So what are the two systems we can actually practically use to remove bacteria out of the air, right? And when you do it out of the air, you need to be fast. There's two systems that really work. One is filtration. Filtration idea is you have a filter, it has very, very fine pores. Bacteria or virus, they fly against it, they get stuck, right? To do that, you can imagine you need quite a lot of power to push the air through that. So it is something you need a lot of pressure gradient to push it through, so it makes quite high energy consumption, and often you can't retrofit it because the pressure you need is very high. But of course, the pathogens are actually gone, right? And the dust is also gone, so that's not that bad. However, it's not completely gone, it's in the filter. So then you have to change the filter and throw it out, and you don't know where to throw it because it's actually specialized for disposal. UV light, on the other hand, does not produce back pressure, so you would fly through that light, the bacteria, a virus get killed, and then the air comes out with dead or inactivated pathogens. So they're not gone, but they will drop down in your rooms, and then you have to basically remove them when you clean. That is one thing. On the other hand, you don't have to change a filter, right? So that is a good thing, and it has way less energy consumption, and you can retrofit it more easily. So both of these approaches are completely working nicely in ducted systems. But what happens if you're in a room like the room we are sitting in here right now? If you place a HEPA filter in the corner of this room without any pump that would push the air through, the air would never go through the filter on its own, simply because the filter is a very tough material. However, what you can exploit is you can exploit the tendency of the air that comes from a human who is relatively hot to rise upwards and then go to the ceiling and fall back down. And this actually happens a lot while we are sitting here all the time. And when you do that and it crosses a UV field, when it does this, all the virus and bacteria get killed when they cross it, and they come back down, and you breathe fresh air while you do it. And you can do that in a way that the natural convection will remove the viruses so efficiently that you have air exchange rates of 30, 60, or even above in a room very easily. You can see down here that is a system test of one of the systems that I was a co-developer in, and we did that in an independent research institute. They were spraying virus here, there in the middle, and then they tried to measure it, and they couldn't measure anything. So they had to change the setup to constantly powering the virus in there to see something, and they said, like, it is the most efficient system they have ever seen. It has air exchange rate of 30, 60, or even more in that room, and it's completely silent, it doesn't require a fan, and it's totally safe to use with humans present in the room. The trick with UVC light is, we've already heard from the speaker before, he obviously doesn't like it that much, but it is highly efficient, right? So it actually kills efficiently microbes. So the killing doses you need are also very well established. So we do have data that goes back a long time and long lists that you have it. However, the problem with the data is it varies a lot. So even in these guidelines for E. coli, for example, you will find for a log10 reduction, you will find between 0.4 and 10 millijoules per square centimeter that you need to kill it. Why is that so different? Because most of this data comes from water film experiments, which have nothing to do with aerosols floating in the air. That means you have to do your measurements independently to understand that. And what we have done, for example, for the systems, we generate aerosols that are close to what the human would exhale in an S2 or S3 lab. We throw them through the UVC light, and then we do bacterial or viral culture to see how many have actually died. And when you do that, you find out that we can get a 3-log reduction, like 99.9% in 0.1 seconds. Like most of the systems you will see here will give you that in 1 hour. This system will give you that in 0.1 seconds. So meaning that the air, when it goes through once, you already have a reduction that's way higher than any N95 mask that you can wear. So why use UVC? Well, UVC is invisible light, and it is at the peak germicidal activity because it actually gets absorbed in water so quickly that it does absorb all its energy in a very, very, very short fraction. This makes it ideal for aerosols because aerosols are also very, very small, right? And it can be bundled by specialized optics, which is really good, and there is no possibility for actually to get resistant. It is absorbed so quickly in aerosols they cannot even cross the human skin because it is absorbed in the upper layers of that skin. Even if you would be directly exposed, which you're not in a system like that, but even if you would be, you wouldn't feel it because it can't go in. And it's active against all known replicative organisms, of course. Right. You have to be aware if you use any systems like that, though, that the wavelength is not too short because otherwise you get ozone or you get volatile organic compounds. If it's too rich in energy, then you can get that. So we make sure the wavelength is tailored in a way it does not produce this. Now we come to the implementation barrier, and we all know that is probably the biggest fish to fry in the whole thing. Why is it? Well, because humans cannot stop breathing. We had that before, so that means that from all of the hygiene intervention that we normally do, we say this is an OR, and this is what you do in an OR, which is cool. And we say this is, I draw blood, so I need a sterile needle. But I do breathe. I do breathe no matter what I do. So every room where people come together, we have to consider it in our concept when we think about the concept of air hygiene. That makes it a little bit more complex. And the second thing is, I don't want to scare you with it though, because if you just increase the air exchange rate, you're already a big way ahead, right? So you need to get 12 to 20 air exchanges per hour in your room and you will always already have a lion's share of the effect. Now, of course, you need acceptable cost. If you want to retrofit or outfit a new building, you need that. You have to be compatible with existing systems. And you do want to have minimal to no workflow disruption and ideally no training. We know that we have the compliance fatigue a lot, and that's why I put this picture to the left. That's during COVID. You see the nice lady on the left where she has her mask. And this is actually like what happens. A lot of people fumble with their masks. The faces are not the norm face. Actually, in reality, if you look at publications that check that, even an N95 mask in reality is somewhere like 80% or whatever. And if you cough, it kind of lifts off and then it doesn't work. So it is not a way. You get compliance fatigue immediately, so this is not the way we can get air hygiene done by universal masking. It will simply not work. It shouldn't have any noise, wind, chemical pollutants, or light pollution, right? You want it to work in the night when the patient is asleep. You can't have a light on all the time because people have to sleep as well, right? So you want to make it as little interference with the people as possible because that makes it more easy to actually use it. And of course, you want low running costs. Yeah, ideally no consumables, right? So that you don't have to restock on it all the time, like masks and so on. You can't run out of it. Right, and that is me in Ghana teaching in fresh air, which is good. Anyway, so I hope that you have learned something from that, and I hope that you have understood that air hygiene, I think, is an important part of it. And we are confident that one of the solutions that I co-developed in my profession is an interesting option for this. There's multiple other options, as we have just learned, to explore. And I think you have to tailor your needs and see your needs and check which option fits best for you. But one thing is important, go for efficiency. You don't want 1 hour factor 10 reduction, because in 1 hour, I don't know how many people have crossed your waiting room, you need effect in seconds, because that is the air, when you breathe, it moves upward on your body, and it goes like this in a speed of 0.1, 0.2 meters per second. So this is actually the speed it moves like this. If you have 1 hour, it has come full circle, I think 300 times to you back already. So you need to have a fast system, either with an HVAC system or with something like an UV system. Otherwise, your effect will be really bad for aerosol, for the air. I'm not talking about surfaces. This is not for surfaces, right? This is for the air.